Thanks very much, David, and thanks for not butchering my name. It's a great privilege to be able to present my work to you here and be among a group of really outstanding up-and-coming researchers, so thank you very much to the conveners. The background to my paper is that we have known from historical observational studies that after-hours discharge is associated with increased risks for adverse outcomes. The last time the Australian and New Zealand Intensive Care Society adult patient database data was analysed was in 2004. And what you can see here in this paper by Dave Pilcher and others is that although the majority of patients were discharged in hours, the mortality for patients discharged after hours, being after 6 p.m, between 6 p.m. and 6 a.m, was considerably higher, as was the rate of unplanned ICU readmission. And this is consistent with a range of international data. And in response to this data, there are a range of strategies to try to not only reduce the proportion of patients who are discharged from ICU after hours, but also to improve the outcome of patients post-ICU. And these included the Australian Council on Healthcare Standards identifying after-hours discharge as a quality of clinical care indicator, or a key performance indicator, you might say, and also the widespread and probably somewhat variable, although we don't have clear data on this, introduction of ICU outreach teams, rapid response teams, ICU liaison nurses, and in a couple of hospitals, 24-hour intensive care specialists. So we hypothesised that as a result of these interventions, that the proportion of patients discharged after hours from ICU will have decreased, and that also the associated risks of ICU after-hours discharge will have gone down. In keeping with the Australian Council on Healthcare Standards definitions, we defined in hours as between 6 a.m. to 6 p.m. and after hours 6 p.m. to 6 a.m. We obtained ethics approval from the Alfred Ethics Committee in keeping with the ANZICS core standing procedures, and we conducted a retrospective cohort study using ANZICS APD data extracted from 2005 to 2012. We included all patients who survived their initial ICU admission, for whom hospital mortality and ICU discharge time were available. And we broke this data up into 2-year cohorts and analysed it by hour of discharge. We used appropriate statistical tests for continuous and categorical data, and we undertook univariable and multivariable logistic regression modelling for each 2-year cohort, adjusting for illness severity, for presence of treatment limitations on admission to ICU, for the different diagnostic categories, and also for hospital subtypes. And finally, we conducted a sensitivity analysis using data only from those sites that submitted data to the ANZICS APD for the entire 8 years of the study. And there are about 120 sites that did that. So, of the some 710,000 patients that were included in our data analysis, about 110,000 or 15.4% were discharged after hours over the 8 years of the study. You can see here in the Crude data that the mortality for those patients discharged after hours was significantly higher than the mortality for patients discharged in hours. And this is also true of ICU readmissions. Interestingly, the patients who were discharged after hours were sicker on admission to ICU than those discharged after hours. And I'll get to that a little bit later on. And somewhat predictably, the rural and smaller metropolitan ICUs had higher rates of ICU discharge after hours, and the private ICUs had the lowest proportion of after hours discharges overall. This graph shows the proportion of patients discharged per hour over the course of a 24-hour period, and each different coloured bar, I'm sorry if the colour hasn't come out very well on the big screen there, represents each 2-year cohort. And so what you can really see here is that over the 8 years of our study, there was basically no discernible change in the pattern of ICU discharge timing. This is a graph that's been shown a couple of times during this conference already, and what this shows is the crude hospital mortality by hour of ICU discharge. And you can see that the hospital mortality nadir is somewhere between 10 and 11 a.m. for most years, and that from that time, and really most notably in the after-hours periods and in the early hours of the morning, the crude mortality is considerably higher. And also that this hasn't consistently dropped over the course of the study. The variation that you see in the early hours of the morning is due to the low absolute numbers of patients who were discharged at that time. And this related graph is the odds ratios of hospital mortality for by hour of ICU discharge, referenced against discharges between 10 and 11 a.m. for each year. And that was the period, except for the 2007-8 cohort, that mortality was the lowest. And what you can see here again is that for every hour, and particularly in the after-hours periods, the odds ratio for mortality is considerably higher. When you break this down into the raw numbers, what we can see is that the proportion of patients discharged after hours is really stuck somewhere around 15%. We have not managed to reduce the proportion of after-hours discharges in the 8 years since 2005, and that's probably all I need to say about that. And the other thing is that the absolute number, although there are more patients reported to the ANZICS APD, the absolute number of patients in all our ICUs is going up, and so the number of patients in 2011-12 is considerably higher than in 2005-6. Again, if we look at the mortality, after all mortality rates for all patients admitted to ICU are going down, and you can see that here in 2005-6, the hospital mortality for patients discharged after hours was 7%, and that has consistently decreased, as it has for patients discharged in hours. However, the risk associated with after-hours discharge has not decreased during that time, and again is stuck somewhere around 1.34%, and similar percentages are seen in the readmission data. So, the implications for these findings are manifold, but most importantly, I think the key findings are that we have not reduced the proportion of after-hours discharges, and secondly, that we haven't reduced the risk. So the burning question on everyone's lips is why not? And I think that while we don't have all the answers, one of the what we can speculate really is that our intensive care units, despite some increases in capacity, are still in potential for admissions, are still operating at near or full capacity going into night shifts, and that as a result, when acutely unwell patients come into the emergency department or are in other parts of the hospital, we are forced at that time to discharge, perhaps prematurely, patients who appear to be stable enough to go to the ward. The second possible explanation is that there is key information missed at the time of transfer from the ICU to the ward, and that key treatments might be discontinued until it's too late for that particular patient. And the third possible explanation is that there are unmeasured confounders such as illness severity at the time of discharge or treatment limitations at the time of discharge. And John Santamaria's got some work coming out that examines this particular issue. But I think most importantly what this represents is that there has been a failure of translation, not only by clinicians but also by hospital administrators who provide the extra capacity to allow planning for early discharges from the ICU, and also by policymakers who provide the resources that allow us to manage hospitals efficiently and effectively. So, in conclusion, this was the largest ever study conducted of ICU discharge timing. Unfortunately, despite the external scrutiny of accreditation agencies, after-hours discharges remain distressingly common. Overall, post-ICU mortality is decreasing, but the risks associated with after-hours discharge persist essentially unchanged. And I'd be glad to acknowledge ANZICS Core for providing this very high-quality database and for the assistance of the ANZIC Research Centre in conducting this research. Be glad to take any questions.